Good morning again, everybody. We are pleased to have Steve Keltner, PA, who's practiced in one of Indiana's medically underserved and busiest emergency departments for the past 20 years. He's also served 10 years as an adjunct faculty member in health sciences department at one of the Indiana's premier private institutions, as well as serving 12 years on its board of visitors. Over the past 15 years, he has spoken and written on a wide array of healthcare related topics. Please join me in introducing Steve Keltner.
Is this working? Okay, good. So yeah, my name is Steve Keltner, and I used to be affiliated with this particular fine institution, and just want to say thank you to the IAPA for having us all here, and for these sponsors for making this possible, and to all of you for coming and putting yourselves through what you're going to sit through for the next 45 minutes. As he said, I spent 20 years until recently in emergency medicine, and the transition for me is now full-time into hyperbaric medicine, and people have asked me, that must be nice to get out of the stress of the emergency department. I said, well, it's definitely great to get out of the stress, but I'll remind you that hyperbaric medicine has a lot of pressure. So we're going to have a good time together, okay? I'm a little bit technically challenged, so bear with me on this one. Hyperbaric medicine's been around for well over 80 years, and that's why I gravitated towards that. But let's see if I can work this thing out. They told me I had to have objectives today. I said, well, my objective is not to pass out on stage, and they said, I can't quantify that, so give us some learning objectives. So what we're going to talk about today, and my hope today, is to fundamentally redefine how all of you conceptually look at a wound. Second, we're going to recognize that all wounds require the same tools to heal. And I'm hoping we can gain a new appreciation of how hyperbaric oxygen therapy applies to your population of patients regardless of what your practice is. And then finally, the obvious question is to discuss why it's so underutilized in American medicine. To start out, I'd like to introduce you to somebody. I don't know him personally, but he's become kind of a role model to me. His name is Paul Harsh, graduate, Johns Hopkins School of Medicine, 1980, so he's got a pretty reputable background. He's clinical professor and director of hyperbaric medicine at the LSU Health New Orleans School of Medicine. And I like this quote because I think it sums up everything I've always thought about hyperbaric therapy. And he said that his generation of doctors, they were taught that this was not scientific. The medical community just didn't know how it worked. And that's kind of interesting because if you think about it, it uses pressure and oxygen, two things we know a lot about. And if you focus on the things that he did know, I think a good place to start, and I'm going to go through this kind of quick because my presentation is a little longer than I thought it should be, but they shortened my time. So forgive me if I go too quick, but Boyle's Law, this dates back to 1662 when it was discovered, this is review for everybody, I know, that the pressure of a gas varies inversely with the pressure to which it's subjected, which is pretty obviously seen right up in here. Change the batteries, not working. So if that's the case, then this is what we talk about that few minutes in school we spent about barotrauma and air embolisms. The other law is Henry's Law. This dates back to the 1800s, and this is the one that talks about that at a constant temperature, the amount of a gas dissolved in a liquid is proportional to the partial pressure of the gas. So you can see on the left, we have fewer in the air. The partial pressure is lower than on the right. This leads to decompression sickness and to nitrogen narcosis. Now, back in the 1800s, throughout the world, there was a really interesting phenomenon going on. People were building bridges. And they weren't building little bridges, they were building big bridges. In fact, the largest bridge at the time was actually in Germany. But there was another project in the United States that was pretty big, and it happened to be taking place in the East River, and it was the Brooklyn Suspension Bridge. But in order to build these bridges, they had to have these massive caissons, metal and wood, kind of bowl-ish, if you would, and they'd flip them over and trap air underneath them. And then they had these people called sand hogs that would go down and they'd scoop out all the dirt and all the mud until they could get to the bedrock. And that's where we're going to put the footing for the bridge. So interestingly enough, it wasn't until about 1872 when 3 sandhogs died that they started trying to figure out what was going on. They noticed that these folks would go down and work all day long. And then as they'd come up, they'd start to have a lot of problems. They would have some muscular paralysis, maybe in the hands or in their backs. And they would notice that they had some speech that was slurred. And they also had severe joint and stomach pains. So these people would walk around and they would look like this. And people would say, oh, hey, there's one of those sandhogs, he has the bends. And that's where that phrase came from. So a little bit of review of how the gas laws work. For every 33 feet, which for the rest of the world is 10 meters, the pressure of nitrogen gas goes up 11.6 pounds per square inch. Now what you want to know is that as we increase the pressure, the amount of nitrogen that can be dissolved in a tissue goes up. And the more time you spend at depth, the more of that you're going to absorb. So if you're allowing time for decompression at stops, which is what divers do, they have dive tables. If you go down a certain depth, you come up to a certain depth and you wait and allow your body to off-gas the nitrogen. If you don't wait, what happens is Henry's law takes effect. And as the pressure goes down, the gas's ability to dissolve that gas also goes down. And what you see on the left is an excellent example of that. Anytime you've taken that Coke bottle, that Sprite bottle, or Pepsi, not partial one or the other, you'll notice that you release the gas in the neck of the bottle, and the gas, the partial pressure decreases, and more gas leaves the fluid. That's going to be important for us here in a minute. So the science we did know, Boyle's law, Henry's law, led to a few things. Initially, when they started doing hyperbaric therapy, they just used normal air. 78% nitrogen, 21% oxygen. And it was very helpful. And these are what we all learned in school. You can use this technology for decompression sickness, air gas embolisms. Cyanide poisoning are the one that's the board question for you. If you get the board question, it's carbon monoxide poisoning. A little bit of mechanism of action. We got to go through this because we're trying to learn something here. If we talk about, and these are also very important to why this all works, the dissolved plasma oxygen concentration, as you're all snoozing right now, is 0.3 milliliters per deciliter. If I put 100% oxygen on you with a non-rebreather, just as you're sitting there, I can increase that up to 1.5 milliliters per deciliter. It's pretty significant. If I put you at pressure, I can increase that to 6 milliliters per deciliter. So the amount of oxygen is much greater. Reduction in gas bubble size is Boyle's law. And what we're saying is, and this goes back to, remember those old dissociation curves, but it's very similar. The nitrogen bubbles are reduced in size by Boyle's law. So too are the oxygen molecules. And that becomes important as well. Because if the oxygen is actually smaller in size under pressure, I don't need hemoglobin to move oxygen through your body. I can put it in the plasma, and the plasma will take it there for me. This is back to the board question, antagonism of carbon monoxide. What you're going to see on your board question is the bottom part. It's 4 to 6 hours at room air. For the half-life, it's 15 to 30 minutes with hyperbaric oxygen. It's reduced down to about 25% or less. The other part that's really important, we do realize, and we've learned that we treat diabetic foot wounds or foot wounds in general. And the way that works is that it modulates the local and systemic effects found in both the acute and the chronic injury situations. It decreases inflammation. More on the wound healing. There's reactive free radicals, specifically oxygen-free radicals. Hydrogen peroxide is created in the process, hypochlorous acid, and these actually lead to, and this is very important, reduction in TNF-alpha and also interleukin-6, huge immune modulators that cause inflammation. The reactive nitrogen species, nitric oxide, actually triggers pluripotent stem cell synthesis, up to 800%. Now, this is one of the things I first learned about when I was looking into hyperbarics. I thought, wow, that's pretty cool. I can use gas, 100% oxygen, and pressure, and I can actually make the bone marrow create an 800% increase. It's actually liberated into your bloodstream. That's pretty cool. That's got to be brand new technology. And then I realized, well, that was in 2004. I thought, wow, Well, where have I been? Well, I was nose down in the books trying to save people in the ER. A couple other things we'll go through quickly here. It does decrease the anytime you have inflammation, anytime you have a crush injury, there's a vasogenic edema that can occur. The pressure alone will reduce that. The altering conditions of local hypoxia are kind of important. If you're talking about certain bacteria, specifically the anaerobes, Clostridium, for example, it can't survive it. Too much oxidative stress. It's not the pressure, but it's the oxygen that it can't handle. So it limits Clostridial endotoxin and spores, it kills the anaerobes, augments the neutrophils' bactericidal activity, and inhibits growth of several bacterial pathogens. In many cases, it forms a wonderful adjunct. So if you happen to have bacteria like Pseudomonas aeruginosa, which is a difficult bug to kill, putting them in a hyperbaric therapy chamber along with their antibiotics actually increases the ability of the antibiotic to work. So the science that we just talked about has led to this number of treatments as being acceptable to insurance companies and to practice in general. These are our limitations. And part of the problem with this is that, as it says at the bottom, it was last updated by the Undersea and Hyperbaric Medical Society in 2014. And that's a few years ago. And things have changed even since then. But looking at this particular list, I thought, well, there's a couple that stick out to me that I think are interesting. And those two are number 8, intracranial abscess, and 15, the non-healing diabetic wound of the lower extremity. Because in reality, although probably right now none of you are thinking of them as similar, they're actually very, very similar. To get to that, let me discuss what a wound is. Because as soon as I say a wound, everyone comes up with an idea in their head and a picture in their mind. And it's probably some diabetic foot ulcer or a little cut on the arm. But by definition, a wound is a disruption of the normal structure and function of the skin or soft tissue architecture. So a disruption of the structure and function. An acute wound demonstrates normal physiology, so there's a very specific progression that it goes through, and we've all seen that. And then there are also chronic wounds that are defined as one that is physiologically, and I threw this in there, this is not their definition, it's mine, metabolically impaired, because the metabolism is the key. So this is a wound. I think everyone would say, yep, that's a wound. And we would agree that this is a diabetic foot wound, hard to see here, probably like a Wagner 2, if anyone cares, which if you're not in hyperbaric therapy or not in wound care, you probably don't know. But the bottom line is it's chronic, there's significant inflammation, and a significant decrease in perfusion. There's a lot of interleukins here, TNF alpha is high, and the most important part for discussion, I call this a low-tech wound, because I can look at it. This is a high-tech wound. I can't look at it without going through some type of an adjunct. In this case, we're looking at a scan, and it shows the, you can see it there, that it has the hole kind of in that space. And that is a brain abscess. And the damage is primarily done, it's acute. Typically our body tries to fight it, and that causes inflammatory markers and destroys the tissue. So there's significant inflammation, and there's decreased perfusion. So high-tech wound, low-tech wounds. I'm going to change up just a little bit though, because brain abscesses aren't something we see very often. And something we do see more often is a stroke. Now, cerebrovascular accident is definitely, looking at this brain, a disruption of structure and function. The structure has been changed, and we all know that the functions change afterwards. It can be treated chronically or obviously acutely, and there is significant metabolic dysfunction. We've talked about the penumbra, that's that area around. On the left side, we have healthy brain. On the right side, we have a necrotic area with kind of a yellow brownish area, and that is metabolically dysfunctional. So if I'm looking at these two wounds, I think, yeah, they look pretty similar. I've got black necrotic areas in both of them. I have areas of healing or just metabolically dysfunctional tissue on the outside that are trying to heal and just need some help. And the fact is that hyperbaric therapy can actually regenerate that metabolically dysfunctional tissue. Now, if I want to talk about regeneration, I have to think about what exactly would it take to regenerate tissue? And the masters of that, as this study called it, the masters of regeneration are the newts. It's because a newt can actually regenerate its entire limb. Now, a lizard can do the tail, but it's usually the muscles only and the skin. It's not a bony structure that they can regenerate. But newts have that uncanny ability to produce the limb. And these guys had a neat little study where someone, well, we're all scientists, they basically removed a limb to find out what exactly was going on at the site of regeneration. And they found high concentrations of oxygen and a muscle stem progenitor cell. So for a fire-bellied newt, the regenerative process starts when the trauma happens. And if that happened for us, that would be fantastic. If you're in an accident and lose a limb, no worries, just wait, it'll come back. It doesn't work that way, obviously. What we do is we stick them in hyperbaric chambers. And these have changed a lot. These are actually the chambers at my clinic. They're clear-sided, you can see through them. They used to be, you'd get a tiny little hole you could peek through, it was a solid metal. So these are not anywhere near as claustrophobic as they used to be. But for us, the regeneration comes from the fluctuations in going down to atmosphere and coming back up. It's the repetition that causes that trigger. So I've got a trigger now, that's good. In order for the body to heal, we got to have energy. The cells need energy. And going back in time, we've talked about how oxygen plus nutrients create ATP. On the far left, glycolysis, not the most efficient process. 2 ATP. Krebs cycle gives us 36, far more. So we want to have oxygen to regenerate our bodies. And as I was doing research, I kept seeing this phrase, ER stress, come up. ER stress. I'm like, look, I don't want to learn about ER stress. I've been there 20 years. I know everything there is to know about ER stress, and I don't want to see it again. But then I stumbled upon this picture. And it was interesting because I started to realize that, wait a minute, they're talking about something different here. And basically, if you can believe it, they just realized not too long ago that the endoplasmic reticulum is actually very highly subjected to oxygen levels in how it performs. I mean, who thought? I thought we knew everything about the ER, right? So as it turns out, briefly, what you see is if you have mild hypoxic conditions, what happens is the protein translation gets misfolded. These proteins get misfolded because the disulfide bonds can't be formed without high oxygen. And as a result, those misfolded proteins can aggregate. Now, one place we've heard about that probably is Alzheimer's disease, with the aggregation of the beta or tau plaques. So that's going to be something we'll talk about in a minute. The other thing we need is a way to fix the body. Got to have a way of doing that. Now, if you go and do bone marrow transplant, they're going to pull out the multipotent stem cells. And those are good. But remember, I said that we have an 800% increase in pluripotent stem cells. And those are better. The fact is we don't use them very often because there's many concerns with them, basically ethical concerns. But if I can turn your stem cells on, I don't need to harvest them from someplace else. And the last thing that we're going to need is we're going to fix the body. We got to have a way to support that. And this process of hyperbaric therapy has been well known and well documented for decades that it actually produces angiogenesis, which is pretty cool. Let's say you have a microvascular problem, ED. Well, there's a way to fix that. In fact, studies that have done hyperbaric therapy have shown over 90% rate of healing that process. We're building new capillaries to supply instead of the microvascular that's diseased. And the good news for them is actually these new capillaries that we create are slightly leaky, which is actually good for ED. So even though you probably didn't think that we could have any effect on erectile dysfunction, we can. So now the tools. We talked about what are the tools? Well, we need the four things. We have the trigger for the regeneration, we have the energy, we have the stem cells, the pluripotent cells kind, and we have angiogenesis. And that is the toolbox for fixing a wound. So where does hyperbaric therapy go? Well, Aetna Insurance, and I'm not picking on Aetna. In fact, Aetna has one of the best websites of all the insurance companies out there on this topic. And as I sat down, I thought, well, do I really want to write out 115 different possible indications? No. So I took a shortcut and I decided, well, if I looked at these things by practice area, and that's what these are, you get an idea or a flavor that if you're in any of these practice areas, and there's probably a few I missed, hyperbaric therapy could actually help your patients. So I'd like to talk about three in particular. And I want to focus first on that top section where it says, Aetna considers the use of systemic hyperbaric oxygen therapy as experimental and investigational for the following conditions. And it's not all inclusive. And here's the part I want to key in on. Because there's insufficient evidence in the medical literature establishing that systemic hyperbaric oxygen therapy is more effective than conventional therapies. I challenge that. And I think after this, you will too. And interestingly enough, the stroke actually isn't one of the indications on the list of their 115. So I'm going to take them in reverse order. We're going to start down with traumatic brain injury and we're going to work our way up, just indication of severity. So currently, Center for Disease Control says if you have a patient who has a concussion, or what we call MTBI, mild moderate traumatic brain injury, we should rest them, take lots of naps, limit physical activity, thinking, and concentration. Now that to me does not sound like treatment. To me, that sounds like management. That's a very, very important distinction. I tell you that we can do better. Now, a little bit about how this all fits together. The neurons, we're going to focus a little bit of review here for the neurological stuff because I guess I slept through part of neurology. So I hope everyone else doesn't feel bored by this, but I think it's important to recover the fact that neurons require significant amounts of energy to function normally, especially when they're talking to each other. And energy in the brain is almost exclusively derived from the metabolism that requires oxygen, as we talked about later. It doesn't like glycolysis. Neurons only maintain a very small amount of energy in reserve. Therefore, there has to be a continuous supply. And that tends to be part of the problem. Now, imagine if you happen to have neurons that are injured, just like anything, it needs more oxygen. This is actually a pretty cool map of vasculature of the brain. I threw it in because I like it. Something must give away when the demand exceeds supply to the brain. So when people have these concussions, they can have some of the esoteric things, I call them. They may have concentration or memory, recall issues, mental fog, or sadness, anxiety, and irritability. Or they can have things that we can see more visibly. They might have a gait issue, they may have, or balance. They may be complaining of headache. They may just feel fatigued. Some people have photophobia, and the one I find really interesting is buzzing. I haven't figured that one out yet, but I've got another 10 years in me to try and figure that one out. Treatment requires understanding, and this is where I'm really hoping we can make some headway to get together today. The brain is approximately 2% of the body's mass, but it consumes about 20% of the oxygen taken in. Now, I put 20 to 24 because I've seen studies that actually say 22. I saw one that said 24. But for argument's sake today, we're going to say 20 because that's what the majority of them say. And the brain is continually using all of that energy, all of that oxygen. And it's got this neat little choreography that goes on. It's continually shunting oxygen from one part of the brain to the other. So as I'm standing here and say, okay, I want to lift my right arm, it shunts oxygen to that part of the brain. Now, obviously, a certain part of it can't be utilized any other way. It's got to keep the functions of the brain going, those basal metabolism functions. But I like this picture because a lot of the old guys like myself in here will tell you that there's been years before hands-free devices were in cars. We're driving down the road, we're talking to somebody, and all of a sudden you're like, oh wait, hold on a second. I just missed my exit. All right, I'll drive up, turn around, come back. Yeah, no, I just missed my exit, I'm sorry. What were you saying? And the reason that occurs is because we're great multitaskers to a certain point. At that point, you need to use more oxygen to figure out your path. So I have to exit the phone call for a minute. And that's just the way the brain is. You only get 20%. There's no other way to get around it. The problem is, and I see a lot of this when we're talking about concussion, that when you injure a portion of the brain, wherever the concussion occurs in your brain, it actually changes not just functionally, but physically. And this is something that's actually fairly new. For a long time, it's just been said, well, there's a functional deficit, but it goes away. The fact is that through this process called acute rarefication, in the area of the brain where the injury occurs from the trauma, there's a decrease in blood vessel junctions where they branch off by 33%. And the amount of length decreases in that area by 22%. But we just said that a brain that's been injured, the neurons need more oxygen, not less. Now this was kind of new, and I threw this in there just for all those, because you all have access to these slides. But the bottom line is, acute rarefication, not something I found somewhere crazy and just threw it in here. It's been documented in numerous studies, so it's out there and it's fascinating stuff, but it still leaves us with an issue. What do we do about the fact that the demand is exceeding the supply? One thing that we notice in concussions too is that headache is very common. One of the first complaints people have. How do you feel? I just have a headache. Well, headache, if we want to go a little deeper into neurology study here and say, well, it's part of the pathway of hypoxygenation. If you're looking at high altitude sickness, for example, non-traumatic, if someone first starts experiencing the effects of the high altitude, they'll start to get the headache because at altitude the partial pressure is decreased oxygen to the brain. So we follow this all the way down from hypoxia down to migraine headache. There's another place that we also see that in the emergency department, in practice in general, that when you start to have a demand that it exceeds the supply, and that would be an acute coronary syndrome. Now, it seems to be okay for us to tell a traumatic brain injury patient, go to a dark room, relax, don't do anything, maybe take an aspirin, you'll be fine. But we would never tell this patient that. What we're going to do is tell them, sit down, I'm putting you in observation, and tomorrow we're going to put you in a Lexi scan, and we're going to figure out if you need a bypass, an angio, or if you need a stent, but we're going to get it taken care of. The difference, of course, is that's treatment, and that's a big difference. Rest is not treatment. It's management until I can treat them. So let's get into some of the studies, because that's really the fun stuff that we're here for. And they actually excite me the most, because all the mechanisms of action kind of are like, okay, great, test is over. There's a test starting in 2017, and this test has actually been continued to a current state. But initially, it was done by a Dr. Denham. I believe she was originally in Chicago, I think now actually in South Dakota. But either way, she took 52 patients. The only criteria for age didn't matter, none of that. What mattered for this was that they were no more than 10 days from their traumatic brain injury. And the protocols are listed there, but the bottom line is this. The patients were treated until complete resolution and without regression, so their symptoms didn't come back afterwards. And if someone said, gee, doc, I'm just not sure if I'm feeling, I think I'm back to normal, but I'm not sure. They were put in for another treatment. And I inadvertently call them dives, which I'll clear that up now. It's because it has its association with diving and with decompressive sickness. We don't call them treatments, we call them dives. So sorry if there's confusion there. But here's the key. Of this study, 51 of the 52 patients had complete resolution of their concussion symptoms in 5 or fewer dives. In fact, the average number of dives or treatments were 2.4. This study has been extended to a more current time. Recently, the number is 350 patients. 348 of those patients had complete resolution. That's 99.5%. Now, I know it's a small study, but the power is pretty decent. And more studies are being done like this, and they're pretty much coming up with the same results. But it's interesting that even just the first two dives, we had an amazing amount of resolution. So why does it work with traumatic brain injury? Well, neural cells, as we talked about, they're wounded. They're not dead. They're just metabolically dysfunctional, and they need oxygen to heal. There's a lot of inflammation. Acute rarefication is actually potentially counteracted by the angiogenesis. And the trigger to heal is there. It's the pressure. This is treatment. Back to this guy. Dr. Harsh ran a study back in 2017, and it was titled Hyperbaric Oxygen Therapy of Mild Traumatic Brain Injury, Persistent Post-Concussion Syndrome, and PTSD. And he did this on some Afghan vets. And what he found was, when he put them to depth, he dove them to depth, the 152 kilopascals is actually 1.5 atmospheres. He put them down for 60 minutes. We call it going down. So you put them in the chamber, you take them down to depth, they're there for 60 minutes, and then you bring them back up. His were actually for 20 days. So normally we do them once a day for 40 days. The new way to do it seems to be twice a day for 20 days, as long as they're 4 hours apart. And what did they find? Improved physical exam abnormalities and cognition, depression, suicidal ideation, anxiety, quality of life, and brain blood flow, all improved. In fact, the blood flow by the SPECT scanning, MRI scanning, was indistinguishable from the control group after 40 dives. 40 tends to be the sweet spot. You can ask me more why later, but that's pretty much what we do. So if someone has to come in for a full set of dives, it's usually 40 dives. There was a significant reduction in the psychoactive medications that they needed, and 52% no longer even met the criteria for PTSD. The most interesting part of this, if that's not interesting to you, the most interesting part might be the fact that the symptomatic improvement continued for 6 months after they stopped the hyperbaric therapy. It continued to improve. Most probably because the angiogenesis returned the blood supply to those parts of the brain, and they continued to heal. High-tech wounds, cerebrovascular accident. This one's actually a stroke. You can see on the lower left you have the void, and you can see the blood supply. Now, for this particular study was done by Dr. Shai Efrati in Tel Aviv, and he is doing the other lion's share of the work in the world on all hyperbaric medicine. So between Dr. Harsh and Dr. Efrati, that's where the majority of the studies are coming from. But in this particular study, what you'll see is, if you look at the scale on the left, for those who aren't used to reading these, which I really wasn't until I started getting into this, the dark blues and the blacks are bad, and the red is very good. So we look over here, baseline, we look at the red parts of the perfusion scan, and then after the hyperbaric oxygen scan on the top, there's a lot more red, and that which was green is now yellow, and that which was orange or whatever, it just improved. So if you want to say, well, yeah, what was the improvement of that? We look at this bottom one here, and you can see that by percentages they go up. We've massively increased the perfusion to the brain. So this particular patient was a 64-year-old female, hemiparesis from an ischemic stroke, 26 months prior to the inclusion in the study. So that's 2 years, 2 months prior. Her protocol was actually now an older protocol, but after treatment, the important part is the leg hemiparesis resolved. Her hand function was significantly improved, although she didn't regain all of her fine motor function. And that was permanent. It didn't go away, it was permanent. However, it was subject to aging and anything else if she had another injury, just like we all are. Here's another similar study, 62-year-old female who suffered from right side hemiparesis from an ischemic stroke 14 months prior to inclusion in the study. And this one had a little bit more information that we might all kind of key in on. She had no movement of the right arm. Some effort against gravity with the right leg, mild to moderate aphasia, alexia, alexia is dyslexia it happens because of trauma. So you have dyslexic symptoms that occurred from trauma or for some other reason, but you weren't born with it. And mild to moderate dysarthria. She was dependent in bathing, dressing, and required help transferring, walking, climbing stairs, and eating. She did her 40 treatments. After hyperbaric therapy, she had movement of the right hand against gravity, and I thought the leg, maybe I forgot that. Move fingers and hold the leg. Yeah, move the leg against gravity. Got ahead of myself. She regained her speech to an almost fluent level, and her reading capabilities came back. So the alexia resolved. Her ADLs, independent in walking, climbing stairs, eating, bathing, and dressing. Now, it's hard to acknowledge the fact that, well, Steve, I mean, that's just a couple patients, I know. But the fact is, what makes it hard to argue is, while someone could argue that this could be faked, this cannot. I can't change a SPECT scan. It's either happening or it's not. And finally, we're having the proof of why these things happen. Here's another little example. Alzheimer's dementia, and this is a classic example of what a Alzheimer's patient would present with on a PET scan. It's right where the arrow is. That kind of posterior occipital area is blue. It's a great amount of metabolic dysfunction in that area. The blood flow has decreased greatly. So that's classic. This patient was, you might call her the sentinel case study. Back in 2018, I believe it was. She was 58 years old. She had 5-year symptomatology with continual cognitive decline that had accelerated for 8 months prior to inclusion in the study. Her EEGs showed diffuse slowing. The neuropsychological testing demonstrated multiple cognitive deficits. PET scan we just saw. So it's your very typical Alzheimer's patient. Physical exam, confusion following exams, slight tremor, decreased pinprick diffusely, bradykinesia, hyperreflexia, dysdiadokinesia, that's the one where they do things quickly. She couldn't do that. Finger to nose incoordination, and interestingly, and very typically, instability on deep knee bends, tandem gait, which is this one that we all do, and the Romberg. So she did actually 50-minute treatments. And interestingly, they decided, let's see how she does after 20 dives and after 40 dives. So after 20 dives, increased energy and activity level, improved mood, improved ability to draw a face on the clock. That's that cognitive test, that neurocognitive test. Ability to perform her ADLs and work crossword puzzles. Great. After 40 dives, increased memory, increased concentration, sleep improved, her ability to be conversational improved, her appetite improved, ability to use a computer, her anxiety resolved, and her decreased amount of frustration and disorientation. The tremor, deep knee bend, tandem gait, and motor speed all improved. The conclusion of the study, again, this was just one person, the Sentinel study. To our investigation, these results are the largest reported global and regional improvements in brain resting metabolism in Alzheimer's disease. The second line should amaze you, because it did me. It actually halted the progression and showed reversal of symptoms. It's not been done before. Remember, this is pressure and oxygen. The treatment, to be fair, she did have some regression. So they put her back in a chamber, did some more dives, and then sent her home on home O2. Remember, those plasma concentration goes up if you put them on a non-rebreather. So it was just normal baric oxygen. The really interesting thing is they used a drug called rivastigmine, which is known as Exelon. And they used that to stabilize the symptoms. And therefore that suggests that using pharmacotherapy with hyperbaric oxygen, that could actually be the next frontier for Alzheimer's disease. Remember, get them early. Don't wait till they're late. And then get them on an $80 a month drug. Sounds like a pretty good idea. Also, interestingly, I was having a conversation with one of our neurologists, and he said, well, it's interesting because there's a new drug coming out. The FDA just approved it. And he said it's interesting because one of the side effects is a brain bleed. And he's not convinced that it was the best thing to actually okay, but it's the best thing they got. And the reason that they okayed it is to get rid of those tau phosphorylations. They dissolve the tau phosphorylations. Well, we do that too. And the difference is that the cost of that drug is about, right now, it's going to be about $60,000 a year. And ours is about $47,000 cheaper, and you only have to do it once. So maybe old ways are still good ways. So why it appears to work for this? Well, there are 4 pathological processes in Alzheimer's disease. We work on affecting the microcirculation, mitochondrial dysfunction, and biogenesis. We reduce those amyloid burden. We control oxidative stress, and that's key. Some things we do in hyperbaric oxygen therapy are done at 2 atmospheres, and some are done at 1.5. And it changes the amount of oxidative stress. The brain, the neurological type things respond better to 1.5. And then we also reduce the inflammation. So the question we started with, one of them was, why is it so underutilized? Well, I don't know about you guys, but I was taught that there's only 3 things you might use this for, and I think we spent under 5 minutes on it in school. I don't know if that's changed, but out of sight, out of mind. We're still uncovering mechanisms of action. Like I said, we don't know why it's the pressure changes that trigger it, but that's where we have to go. And some people are bothered by that. They're like, well, you don't know the mechanism of action. Well, I say, look, I just spent 20 years telling people to take acetaminophen, guaifenesin, caprolithium, metformin, and pyridium, and I prescribed many of those. And if you look those up, none of them have a known mechanism of action. But we don't seem to have a problem using those. But I don't argue results either. Concerns we hear frequently, well, how expensive is it to use this? I get that. The approved 15 things that we had the list up initially, that's what insurance pays for. They're not here yet. And partially that's the fault of my own medical society for not actually sitting down and saying, hey, we need to look at this new data. Part of the problem is it's every day for 8 weeks. We're now getting it down. I mean, chemotherapy is every day for 8 weeks too. The difference is chemotherapy is important because cancer will kill you. This arguably could have some issues too, such as the fact that if you have a child or a person who has traumatic brain injury, they are 2.4 times, not percent, times more likely to commit suicide in their lifetime. And that goes back to that PTSD thing, which I believe is where, what if the concussion that you get is actually affecting the part of the brain that's your happy center? We know that chronic pain actually changes the way the brain works and the way the blood flow actually occurs in the brain. And if you look at those people after hyperbaric therapy, we also know that reverts back. So there are lasting effects to these things. So don't just think of the 8 weeks or the 20 days you have to spend now. And then there's the cost. If you have a kid who has a concussion brought to you in your office, if you're a PCP, then you send them off to sports medicine, typically where they do the impact training, and then they sit in a room for a while, and then they come back and they retest them. And I think that cost, on a very, very conservative measure, is about $800 to $1,200. If you brought them to me in the ER, and I did not scan them, because I don't scan them very often, there's very few kids that need that to be done. But if I send you to sports medicine to do that same process, you are easily looking at $1,600 to $2,200. Now, I get that that's kind of expensive, especially if you're saying it's out of pocket. But the fact is that if I can tell you I can manage this process for somewhere around $800 to $2,000, or I can treat your kid or spouse or loved one, significant other, for somewhere between $300 and $1,200, I would personally think most people would choose treatment, especially knowing that there are other side effects later in life, such as suicide. I would recommend a new way of thinking about this as well, and that is if you want to look at it genomically. Hyperbaric oxygen therapy actually affects, it expresses or suppresses over 8,000 genes in the body, each cell. And that's pretty important stuff. Because as I tell people, it took 6,720 hours to create you in the first place. 40 hours for a renovation isn't too bad, and I can help with that. So, back to Dr. Harsh. He points out that medicine is pathetically slow, and we know that, but in reality, I mean, sometimes it seems like it moves fast. I think sometimes information is slow. And the science is out here now, and that's what we're here for today. I'm here to explain to you something that I think is kind of cutting edge, and something you can take back and say, hey, wait a minute, we can do better. We need to inform doctors, PAs, the medical societies, and change the perception. And that's our job today. That's what I need your help to do. The ability to move this area of medicine forward relies on you guys. No pressure, but it relies on you guys. Yeah, that was a joke, sorry. So with that, I say, thank you very much for listening. If you have any questions, if you said, hey, I really enjoyed your talk, but now I'd like to tell you what I do for an hour, reach out, call me, email me, head to the website. Be happy to talk to you about how you can actually find ways. I'm happy to put studies in your hand to show you how you can affect, in a very, very positive way, your patient population using a very old technology. Thank you.